Good afternoon. We're about to start this session for vascular surgery. It's late afternoon, and I would have loved to have more attendance, but I'm sure it's going to be interesting for all of us, and maybe more audience will be joining us later, inshallah. I think the first speaker.
دكتور مشرف
معتز
اتفضل البرزنتيشن بتاعتك.
Hello, I'm Dr. Mu'taz Ashraf, Assistant Lecturer of Vascular Surgery Department. This thesis was under the supervision of Dr. Abdurrahman Muhammad, Professor of Vascular Surgery, and Dr. Khalid Adib, Lecturer of Vascular Surgery. Our topic is gonna be, is inframallular angioplasty effective for wound healing in patient with critical lower limb ischemia due to tibial arteries only disease? The prevalence of the peripheral arterial disease is 3 to 12% from population and estimated to be 12 to 20 in elderly patient aged 65 or above. The leading cause of hospitalization and amputation in diabetic patients is foot ulcer. 20 to 40% of healthcare resources spent on diabetes are related to diabetic feet. Foot ulcer progress to major amputation in 8 to 30% of patients with diabetes. Critical limb ischemia is a clinical syndrome defined by the presence of peripheral arterial disease in combination with wrist pain, gangrene, or lower limb ulceration for more than 2 weeks. Critical limb ischemia with tissue loss was associated with 4-year amputation rates in 35 to 67% of cases. Mortality rate within the first 6 months after the diagnosis of critical limb ischemia is 20% and reach 50% within 5 years after the diagnosis of critical limb ischemia. Inframallular disease is a serious clinical problem in patients with critical limb ischemia. It is associated with impaired limb salvage and delayed wound healing. Percutaneous transluminal angioplasty is increasingly being used as the first line of revascularization procedure for the treatment of peripheral arterial disease, even in most challenging areas. Endovascular revascularization for inframallular disease is a reasonable strategy for improving the clinical outcome. According to Kawada, pedal arch is classified to 3 classes. Angiogram in A, showing complete pedal arch or type 1 pedal arch. It shows that both pedal artery and the lateral plantar arteries are patent. Type 2 pedal arch, shown in angiogram B, shows that type 2, according to Kawada classification, type 2 pedal arch, either pedal artery is patent or lateral plantar artery is patent. Type C or type 3, according to Kawada classification, shown in angiogram C, it includes that the pedal arch and lateral plantar artery are both occluded. This angiogram also representation of the 3 types of pedal arch according to Kawada classification. Okay. In our thesis, patient and methods, this is a prospective observational cohort study was done to assess the outcome of inframallular balloon angioplasty in patients with multiple tibial and pedal arch disease by the impact of technical success in the form of angiographically improvement of pedal arch according to Kuwarada classification, and the clinical success by wound healing in 40 patients with critical limb ischemia due to infrapopliteal and inframallular disease. Our study included 40 patients who visit outpatient clinic or emergency room and scheduled for angioplasty. Then their wound healing rate was followed up for 6 months after the procedure. Inclusion criteria include critical limb ischemia, Rutherford category 5 and 6, palpable popliteal artery pulse before intervention, BDIS classification stage 2, 3, 4, multiple tibial artery disease, stenosis or occlusion, pedal arch disease سواء كان incomplete or no or absent pedal arch. Exclusion criteria include patient with absent popliteal pulse, bedridden patient as associated comorbidities, dehydration, and high risk of pressure ulcer show poorer outcome. Patient refusing consent, non-salvageable limbs, previous allergy to contrast. Okay. Table 1 show demographic data of the studied group. It shows that our study group age mean was 60.4 and ranged from 40 to 82. Our study included 12 females that represented 30% of cases and 28 males that represented 70% of cases. Figure 2 showing demographic comorbidities and risk factor in our study group. Current smoking was encountered in 70% of cases, ex-smoker was encountered in 15% of cases, obesity was in 70% of cases, and diabetes mellitus was in 85% of cases, hypertension was in 57.5% of cases, ischemic heart disease was in 60% of cases, and renal insufficiency was in 12.5% of cases. Okay. Table 3 showing technical success after trial of inframallular angioplasty by using plantar loop technique as shown by postoperative angiography. We could achieve grade 1 or complete pedal arch in 12 cases out of 40, representing 30% of cases. Grade 2 was achieved in 18 cases out of 40, representing 45% of cases, and the failure of inframallular angioplasty was encountered in 10 cases, representing 25% of cases. Figure 4 show by graph showing technical success and percentage of each grade after trial of inframallular angioplasty using plantar loop technique. This angiogram showing the plantar loop technique that we used in our study. Table 4 show minor and major amputation following procedure. Major amputation was avoided in 35% of cases, of 35 cases out of 40, representing 85.5% of cases. And major amputation was encountered in 5 cases out of 40, representing 12.5% of cases. Minor amputation was avoided in 16 cases out of 40, representing 40%, and encountered in 24 cases out of 40, representing 60%. This bar graph show major amputation and limb salvage following the procedure. This table show wound healing and wall healing duration of the 3 grades according to pedal arch classification. In the 12 cases that we could achieve complete pedal arch, out of the 12, that 11 of cases could show complete healing of the ulcer. 1% actually, this patient had restenosis, show non-healed ulcer, with percentage of complete healing is 91.7% of cases. In grade 3, that could achieved in 18 cases. Complete healing was encountered in 16 out of 18, representing 88.9% of cases, and non-healed ulcer was encountered in 2 cases out of 80. In grade 3, which was encountered in 10 cases, half of them, 5 cases, show complete healing, and the other half show non-healed ulcer. The healing duration show variation between the 3 groups. In grade 1, the mean healing duration in months was 1.96, and it was ranging from 1 to 4 months. Grade 2, the mean healing duration in months was 2.3, and it was ranging from also 1 to 4 months. In grade 3, the healing duration was ranging from 2 to 6 months, and the mean healing duration was 3 to 3.35 months. Post hoc analysis to compare between the healing duration between the 3 groups show no significant difference between grade 1 and 2, highly significant difference between grade 1 and 3, and significant difference between grade 2 and 3. Comparing the demographic and the different comorbidities and measuring their significance between the 3 groups show no significant difference between the 3 groups. But in comparison between the 3 groups in terms of wound healing show significant difference between grade 1, 2 and grade 3, while non-significant difference between grade 1 and 2. In terms of healing duration, it shows non-significant difference between grade 1 and 2, and significant difference between grade 2 and 3, and the high significance difference between grade 1 and 3. This figure shows a significant difference between grade 1 and 2 and grade 3. These images, figure 10, shows second, third, and fourth toe amputation wound post-inframalleolar angioplasty in 1 month duration. Figure 11 show heel ulcer with debridement healed within 2 months after inframalleolar angioplasty. A discussion. According to Manzi have conducted a study. It was a prospective cohort study in which 135 patients with critical limb ischemia were approached with the pedal plantar lobe technique in order to recanalize the foot arteries. Acute success was achieved for tibial percutaneous transluminal angioplasty in 100% of cases, while acute success for pedal plantar lobe technique was achieved in 85% of cases. Post-operative wound healing was followed up. Manzi concluded that percutaneous revascularization of foot arteries in patients with critical limb ischemia is feasible, safe, and appear to provide a positive clinical result at both acute and mid-term follow-up. Also, Kuwarada conducted a study. In this study, pedal arch classification was described as mentioned before, and shows that the status of pedal arch is independent predictor of wound healing. Katsanos also conducted prospective clinical trial study in which 40 limbs in 37 patients with critical limb ischemia were included. Technical success was achieved in 95% of cases. Provisional coronary inframalleolar stent placement was performed in 45.2% of cases. Castanos concluded that the below ankle or inframalleolar angioplasty for critical limb ischemia is safe, feasible with satisfactory long-term results, while below ankle stent placement show higher risk for restenosis and poorer primary patency. Thank you.
Thank you, Dr. Mu'taz. Next speaker will be Dr. Hassan Hatem. He will speak about modalities of treatment for patients with pelvic venous insufficiency secondary to non-thrombotic iliac vein lesion. Please, Dr. Hassan, stick to the time.
Probably we can agree, both Professor Ayman and myself, to have some discussion at the end of the session. Further.
Good afternoon. I'm Hassan Mukhtar, Assistant Lecturer of Vascular Surgery, Ain Shams University. First of all, I'd like to thank the organizers, the faculty administration, Professor Dr. Ayman Abdel Fattah, Professor Dr. Ahmed Din Hussein, for allowing me to be here today and to have the honor of presenting my talk. So the title is Modalities of Treatment for Patients with Pelvic Venous Insufficiency Secondary to Non-Thrombotic Iliac Vein Lesions. So what is pelvic venous insufficiency and what is non-thrombotic iliac vein lesions? Pelvic venous insufficiency is broadly defined as chronic pelvic pain in females caused by dilated and dysfunctional pelvic veins. It's difficult to diagnose because of overlapping symptoms seen with other causes of pelvic pain. A non-thrombotic iliac vein lesion is defined as the extrinsic compression of the iliac vein symptoms of lower extremity, chronic venous insufficiency, or pelvic venous disease can develop secondary to non-thrombotic iliac vein lesion. Pelvic venous insufficiency is typically reported in reproductive age women, most commonly in those ages of 20 to 30 years. Pelvic varices are reported in up to 30% of chronic pelvic pain patients with no other obvious pathology. However, dilated vessels have been found in asymptomatic women as well. Etiology is multifactorial, and it is thought that there are both mechanical and hormonal factors leading to vein reflux or obstruction with resulting dilatation. Estrogen exposure is considered a possible cause because pelvic venous insufficiency is not typically seen in women after menopause. Mechanical causes may be secondary to intrinsic vein disorders like valve incompetence, for example, vascular compression like Nutcracker syndrome or May-Turner syndrome, or extrinsic compression like, for example, by a tumor or endometriosis. Pelvic venous insufficiency is also generally associated with multiparity. However, the syndrome has also been found to occur in nulliparous women. There are no universally accepted or well-defined clinical criteria for the diagnosis of pelvic venous insufficiency. It is generally described as chronic pelvic pain, at least 6 months duration, and evidence of pelvic vascular insufficiency or dilation on imaging, in absence of any other cause of pain. It often manifests after the first pregnancy and worsens with subsequent pregnancies. A common presenting features would include sensation of a dull ache or heaviness in the abdomen and pelvis, exacerbated by long periods of standing or walking. It may improve when person is in a supine position, typically worsens at the end of the day, may be exacerbated before or during menses, and of course pain during intercourse with prolonged pain after intercourse, which is called the postcoital ache, is very typical. Detailed history and physical examination and imaging and evaluation of other causes of chronic pelvic pain are part of the workup. Evaluation often requires a multidisciplinary approach and may include trials of medical management for other common pain conditions. There are no specific laboratory tests for pelvic venous insufficiency. Pelvic ultrasound is considered the first line for chronic pelvic pain, as it can be helpful in ruling out other diagnoses as well as assessing the valve incompetence through position changes and color Doppler. MRI and CT offer cross-sectional imaging and survey of the surrounding tissues, thus allowing for evaluation of external venous compression, like we mentioned, nutcracker syndrome or compressive tumors. Both are superior to ultrasonography in identifying tortuous dilated pelvic and ovarian veins and broad ligament vascular congestion. However, they are expensive and may require radiation, although they are less invasive than catheter venography. Additionally, it can be difficult to assess direction of blood flow to diagnose reflux. Referral to multidisciplinary teams, including gynecology, gastroenterology, pain specialists, physical therapy, and vascular surgery may be indicated when the diagnosis is suspected to evaluate for other causes of pelvic pain. The first part of the treatment, of course, is the medical treatment, which is considered the first line, including hypoestrogenic state via ovarian suppression and or vasoconstriction, which are the primary goals of medical management. Evidence of efficacy of medical management is limited, and no therapy has shown long-term improvement. Transient pain improvement only has been shown with non-steroidal anti-inflammatory drugs, medroxyprogesterone acetate, GnRH agonists, etonogastral implants, and micronized purified flavonoid fraction. However, the surgical management, which is an option currently available, like the removal of reproductive organs and alteration of venous blood flow, hysterectomy has not been shown to consistently improve pain symptoms and is typically reserved for refractory cases only. Ovarian vein embolization has become the preferred treatment with a mean success rate of 75%, low recurrence rate of only 5%, and relative safety. Surgical ligation of the ovarian vein, either via laparoscopic or via laparotomy, has shown pain improvement in 67% to 75% of patients. However, because surgical approach can only address a limited number of vessels, there may be increased risk of recurrence. Additionally, surgery is associated with longer hospital stays, recovery times, and higher risk of morbidity. However, surgery can concomitantly address other causes of pain like endometriosis or adhesion. So as we see, if there are no other causes, the endovascular option is very preferred. And this figure here is showing the treatment of non-thrombotic iliac vein lesion, like an algorithm, showing by the history and physical examination. If non-venous causes can be excluded, if it cannot be excluded, then work up and treat non-venous underlying cause. But if the answer is yes, so we move to the next part. Is there refractory or edema or venous claudication, persistent or stasis ulcer? If the answer is no, then we continue on conservative management. However, if the answer is yes, like if we have venous ulcers or venous claudications, so we move on to the non-invasive imaging studies, like the duplex or the CT venography or the MRV, to look for evidence of extrinsic compression. If there is no evidence of compression, so we consider other non-venous diagnoses, such as lymphedema, for example. Or if the answer is yes, we do a catheter-based venography, preferably to be IVUS guided, and to consider the stent placement, which is the best modality of treatment for the non-thrombotic iliac vein lesion in this case. However, the treatment of patients with pelvic venous insufficiency secondary to non-thrombotic iliac vein lesions, which is the topic we are speaking today, the cornerstone of the treatment is the treatment of the cause by endovenous stenting of the iliac vein by self-expandable dedicated venous stents. Adjuvant treatment of the pelvic varicosities by embolization of the refluxing pelvic veins, either the gonadal or the internal iliac veins by coiling or by gel foam or sclerosing material like etoxysclerol. This is the follow-up of patients, and it's the last thing I'll speak about, and it's very important. So this is like a score called the pelvic venous clinical severity score to help with the prognosis and the follow-up of the patients. It's like a questionnaire we do with the patients with pelvic venous insufficiency. The signs of abdominal pain, heaviness, discomfort, pain, dysuria, atypical varicosis, dyspareunia, menstrual disorder, and each one we give a score of 0, 1, 2, and 3. Collectively, we give a total score, and we follow up the patient by this pelvic venous clinical severity scoring system to see if there is improvement or not. Thank you.
Thank you, Dr. Hatem. We'll have discussion certainly about this very interesting topic you have just exposed. Now it's a pleasure to present our following speaker, Dr. Mohammed Hosni. It's about risk factors and outcomes of colonic ischemia after abdominal aortic aneurysm repair. And I'm proud to say that Dr. Hosni is often with us also at Wadi Nil Hospital, and he has been doing a very good job with very challenging cases so far. Thank you.
Good afternoon, gentlemen. At first, I would like to thank Professor Dr. Ayman Abdel Fattah, Professor Dr. Imad Hussein for giving me this chance to present this interesting talk today. I am Mohammed Hosni Ibrahim, Assistant Lecturer, Vascular Surgery Department in Shams University. Today we are talking about the colonic ischemia which present after the aortic aneurysm repair. Colonic ischemia remains a major adverse event following abdominal aortic aneurysm repair associated with high mortality. The incidence of clinically significant colonic ischemia is in the range of 1 to 3% following elective surgery and 10% following emergencies or rupture. When routine postoperative colonoscopy is performed, the incidence is higher. Perioperative risk factors include, and we will try to arrange them into patient-dependent risk factors and surgical risk factors. At first, increase or the age, renal impairment, hypertension, and smoking is considered one of the major risk factors for developing colonic ischemia post-repair. Perioperative variables include indications for surgery, ruptured and versus elective with higher risk with ruptured cases, type of the treatment, EVAR versus open with higher risk in the open cases, and operative details regarding the duration of the surgery, the blood loss, inferior mesenteric artery reconstruction, and the site of the distal anastomosis, hypogastric artery embolization or coverage. These factors can lead to intraoperative hemodynamic disturbances, making the patient more prone to develop colonic ischemia. The aim of our study today is to assess the risk factors related to the development of the colonic ischemia, the overall mortality, and the incidence. This is a gentle reminder of the anatomy we are talking about. This is the abdominal aorta, the celiac trunk at the level of the T12, the superior mesenteric at the level of L1. Here is the middle colic and the arch of the Raylan and the marginal artery of Drummond, and the L3, the inferior mesenteric artery. Regarding the clinical history had a concern on the abdominal pain related to meals and bloody diarrhea, physical examination in patients with suspected postoperative ischemic colitis, and the early hallmark of mesenteric ischemia is severe pain that's out of proportion to the initial physical examination. The abdomen remains soft with little or no tenderness, mild tachycardia may be present. Later, as necrosis develops, signs of peritonitis appear with marked abdominal tenderness, guarding rigidity with and no bowel sounds. The usual signs of shock develop and are frequently followed by death. Those patients with highly suspicious of colonic ischemia who are done for colonic colonoscopy, they are classified according to stages. Stage 1, patchy mucosal erythema. Stage 2, there will be superficial ulcers. Stage 3, there might be blackish discoloration, and stage 4, there will be deep ulcers. How we will present our topic, there are various papers which are published regarding the colonic ischemia. One of them, the risk factors and outcomes for colonic ischemia after abdominal aortic aneurysm, which was published by one of our seniors, Dr. Mahmoud Mashrif. The range, as I said before, was 1 to 3% after elective surgery, with 10% in cases of rupture. And as we are discussing the results, it proved that the results of this study provide supporting evidence that repair for a ruptured abdominal aortic aneurysm, open repair, and need for blood transfusion were the most important predictors of postoperative ischemic colitis. Other factors, patient factors, like the age, the gender, female gender were more prone to developing ischemic colitis, diabetes mellitus, hypertension, coronary artery disease, CKD, as well as the operative factors such as the long duration of the surgery, excessive blood loss, and ischemia time, and the using of the common femoral artery as the site of distal anastomosis during the open repair, and the interruption of the hypogastric artery because of ligation or occlusion. All of these predictors increase the incidence of developing ischemic colitis post-operative. And since ischemic colitis has been developed, the post-operative mortality, 30-day mortality rate and the ICU stay has increased and was much worse in the ischemic colitis cases. Another study emphasis on the early identification of risk factors to crucial high mortality involved with ischemic colitis after abdominal aortic aneurysm repair. There are common risk factors with the previous paper published, but in this paper, it was considering the variables like the acidosis, the hypothermia, and the hypovolemia, as well as the clamp time duration, which also played important factors, which when controlled, it led to diminishing the hazardous complication of ischemic colitis. Another paper, identification of perioperative procedure and hemodynamic risk factors for developing colonic ischemia after ruptured infrarenal abdominal aortic aneurysm surgery. In this study, it focused on 3 other factors, like the use of the norepinephrine in the ICU, which once it exceeded the range of 64 microgram per kilogram, it increased the incidence of ischemic colitis, the operating time above 200 minutes, and the acidosis. Another paper, incidence, predictors, and outcomes of colonic ischemia and abdominal aortic aneurysm repair. In this study, it considered the acute postoperative renal and respiratory insufficiencies, which were related to the occurrence of colonic ischemia. And once colonic ischemia has occurred, it associated with greater hospital mortality. The study risk factors and outcomes for bowel ischemia after open and endovascular abdominal aortic aneurysm. In this study, it was considering the risk factors of congestive heart failure, which increases the incidence of ischemic colitis, transperitoneal approach, supracelia clamping, and inferior mesenteric artery reimplantation. More than 1/3 of patients who developed postoperative bowel ischemia in this study died within 30 days after abdominal aortic repair. The factors associated with mortality after bowel ischemia included surgical management and postoperative renal failure. And this is a simple discussion regarding the various risk factors mentioned that led to colonic ischemia post-operative in abdominal aortic aneurysm repair. It was suggested that female gender and higher age and blood loss with the need of the intraoperative or post-operative blood transfusion were independent predictors of colonic ischemia. The incidence of clinically significant colonic ischemia was more in open surgical repair than in EVAR, more in cases of rupture aortic aneurysm repair than in elective repair. Acute postoperative renal and respiratory insufficiencies were also related to the occurrence of the colonic ischemia. During the procedure, it was important to spare one of the hypogastric arteries. Interruption of the hypogastric artery because of ligation or occlusion during open repair or embolization during EVAR was an important predictor of postoperative ischemic colitis. And the median time for diagnosis of colonic ischemia was postoperative day 2, with the majority of patients diagnosed within the first 4 postoperative days. This is the most important critical in the patient's hospitalization, when physicians must be aware of the serious complication. And the 30-day mortality was much worse in patients with postoperative ischemic colitis. Thank you.
Thank you, Dr. Muhammad Hosni, for being stick to the time and for nice presentation. Next and last speaker will be Dr. Mustafa Muhammad. He will speak about outcomes of tibial balloon angioplasty in patients with single tibial runoff on wound healing. The floor is open.
Fine. Thanks, dear professor. We'll start. Okay. Introduction. We start. The lower extremity peripheral arterial vascular disease is between 3 to 12%, and if the peripheral arterial disease left untreated, it can lead to limb loss and in severe cases will lead to mortality. As we know, chronic limb-threatening ischemia defined as presence of peripheral arterial disease in combination with breast pain or tissue loss in form of gangrene or an unhealed chronic ulcer more than 2 weeks. In a systemic review of 13 studies of patients with critical limb-threatening ischemia who didn't receive the revascularization, which include patients enrolled in medical and angiographic therapy trials, there was about 22% of all cases mortality rate and 22% rate of major amputation at median follow-up of 12 months. Procedure may be endovascular or surgical approach according to anatomy of the lesion and the type of wound and lesion and degree and the length of the stenotic or occlusion of the vessel. Percutaneous transluminal angioplasty is increased being used nowadays as the first line in treatment, especially in more advanced atherosclerosis and lesions infrapopliteal areas. Achieving single vessel inflow to the wound is an acceptable endpoint of peripheral vascular intervention for chronic limb-threatening ischemia with tissue loss. In patients who have progressed to chronic limb-threatening ischemia, revascularization of the affected limb plays an important role in saving limb and prolonging survival rate and quality of life. And this study will show the outcomes of single tibial artery angioplasty in critical limb ischemia. This class classification, as we show in first class, focal stenosis of tibial less than 3 centimeter. Grade 2 or class 2 stenosis involving third of total vessel length, may including focal CTO, but less than 3 centimeter. Not including tibial trunk or tibial origin. This is up to 2/3. Class 3, this is up to 2/3 of vessel length, CTO of 1/3 length, but not including tibial trunk. If including tibial trunk or CTO more than 1/3 of the vessel, or diffuse stenosis more than 2/3 of vessel, will progress to class 4. Patient and methods. This is a prospective observational cohort study which was done to assess the outcome of tibial balloon angioplasty in patients with single tibial run-off by the impact of transluminal angioplasty, including 40 patients with different wound healing. Our study included 40 patients to visit our clinic or our patient emergency room. Inclusion criteria about between critical limb ischemia, Rutherford category 5 or 6, which include ulcer or gangrene, palpopopliteal pulse, because we're targeting tibial vessel, severe tibial disease involving 2 or 3 tibial arteries, as we're targeting single vessel. Patients presents with foot infection involving forefoot or midfoot. Exclusion criteria: patient with 2 patent tibial vessels, non-salvageable limb, chronic kidney disease, GFR less than 30, heel ulcer, patient allergic to contrast. As we show, this is perioperative angioplasty, angiography, and success. Transluminal wire guiding passes the lesion to dorsal pedis artery. This is successful balloon dilatation, and we are intraluminal with direct angiography. This is wound follow-up healing for transmetatarsal amputation all over 6 months. Results. Here is a demographic data of studies about a range of age from 50 to 75, 23 males, 17 females, and this comorbidities between diabetic hypertensive, ischemic heart, renal insufficiency, and degree of kidney disease. 17 patient has gangrene, 12 has ulcer, 11 mixed gangrene and mixed gangrenous ulcer. Target vessels 15 anterior tibial, posterior tibial 11, peroneal 14, total 40 vessels. Success, technical success, anterior tibial artery triphasic, 8 patients, posterior tibial triphasic 4 patients, peroneal triphasic 14 patients, anterior tibial pulse in 7 patients, posterior tibial pulse in 7 patients. Follow-up duplex after 1 month, patency 100%. Follow-up duplex at 60 months, patency maintained 33, and restenosis in 7 patients. This is some complication we have in the procedures. Perforation of 2 patients in dissection, 2 patients, groin hematoma 2, superficial ecchymosis 2, scrotal hematoma 1. The salvage limb was about 36 patients. 4 only proceed to Plony amputation. Minor amputation for 30 patients. Varies from little to amputation till transmetatarsal amputation. Ulcer healing healed in 32 patients. Delayed healing in 3 patients. No healing in 5 patients. Duration of healing range from 1 to 6 months. Limb salvage 36 patients and 4 progressive to Plony amputation. Conclusion. Our study suggests that single tibial angioplasty has effective role in improving the foot wound healing, shortening its duration in the chronic threatening limb, chronic ischemia in patient, improving limb salvage and quality of life. Thank you.
Thank you, Dr. Mustafa. Actually, all the topics that have been displayed are, I would say, our bread and butter in the department. So we, on the one hand, we are happy to listen to your daily protocol that we agreed upon in the department, but at the same time, there are a few refinements that have to be discussed so as to upgrade our practice, all of us. With the permission of my co-chair, Professor Ayman, I will start by first Dr. Mu'taz, and he was echoed by Dr. Mustafa at the end, one way or the other. Number one, Dr. Mu'taz, of course, this is just a misnomer. Critical limb ischemia is now being called critical limb threatening ischemia, CLTI. في الرسالة طبعا لمسات الدكتور عبد الرحمن واضحة برضو كده معاك الحقيقة يعني، ولكن I have a comment. Inclusion and exclusion criteria كانت واضحة جدا جدا, and it was perfectly in place. However, one of the missing spots over here are the impact of that, what you have said. Dr. Mustafa, he touched base on this. What is the impact of this on the angiosome concept in general?
Yeah.
What's your opinion?
Okay. I was.
Do you follow the angiosome concept or not?
Yeah. Inframillar angioplasty is alternative procedure if angiosome targeted angioplasty have failed. For instance, if a patient have ulcer, we targeting posterior tibial artery according to angiosome concept. If failed posterior tibial artery angioplasty, we targeting inframillar angioplasty to upgrade the arch state from incomplete or absent pedal arch to complete pedal arch. It's alternative
على
procedure.
فكرة يعني الانجيوزوم concept we thought it was here to stay, but وده كان سؤال في الام دي اكتر من مرة طبعا دكتور ايمن عارف.
Yeah.
It is not really here to stay because of two things. Angiosome concept is based on anatomy and anatomical variations. You have mentioned it, Mustafa about mentioned. variations in the pedal arch are there always.
Of course.
So it's not based on hemodynamical concept, but rather an anatomical one, which is
Okay.
one of its weak points. Number two, we all of us, and you even better than us, we have seen cases where you have targeted, considering the available artery, the available crural or tibial arteries during the procedure, we have targeted one which is not coinciding with the angiosome, still the ulcer has healed. Number three, recurrence of the lesion, you are talking about critical ischemia. All what you need is a window of time for the lesion to heal or the pain, the rest pain to disappear. So that's my comment. Recurrence of the lesion does not necessarily mean the recurrence of the symptoms.
Symptoms. Yeah. Yeah.
Because you have mentioned it, 50% roughly would probably die within a couple of years because of the natural history of critical inflammation, and 50% would be ending in amputation anyway.
Yeah.
That's my main point.
Okay. Thank you.
Thanks, Dr. Mu'taz. I have rather than comment rather than question for Dr. Hassan for his new hot topic, which is venous congestion syndrome. Recently, there is a new name. It is not a pelvic congestion syndrome. It is now pelvic venous disorders. And you have chosen the venous clinical severity score, which is still working, but there is no new classification and reporting system specific for the pelvic venous disorders, which is the CVB classification, the clinical anatomical pathophysiological classification. This is a specific recent scoring system and reporting system for the venous pelvic disorders. Also, in the pathophysiology, you have to mention your zones. You are speaking about non-thrombotic common iliac, which is considered as zone 2. Okay, there is 4 zone now for the pathophysiology of pelvic venous disorders. This is you are speaking. This is on the common iliac, okay, artery, which is the zone 2, okay. Last, I appreciate your presentation, and thank you.
Thank you. Thank you, Abi.
We are proud to mention that last year في المؤتمر بتاع الجمعيه الجديده اللي هي الجمعيه المصريه للجراحه التوعيه الدمويه والقسطره التداخليه، كنا ناقلين من عين شمس، وطبعا كان التيم ليدر ساعتها كنت انا يعني رابط على الهوا two very interesting cases. One was I think like a navel متهيألي وكانوا متحضرين ميترنال الحقيقه، ولاقت استحسان كثير جدا من الاجانب الدكاتره اللي كانوا موجودين. انا كنت في القاعه وعارف، ونقلت ده نبض القاعه للدكتور ايمن والدكتور حجاج. فعندنا في القسم this productivity has to be shown repeatedly و maximal exposure من خلالكم تحت اشراف طبعا الاستاذ الدكتور ايمن. ولكن يبقى سؤال بقى ده يعني الحقيقه which ones of the pelvic escape points should be left and which ones should be attacked on the same sitting. يمكن تختلف فيها بعض الآراء. There is no consensus and it's not exactly mentioned in the guidelines, but one thing for sure, careful with the initial CT venography. Please make sure that your colleague radiologist, or if, because we depend on the CT venography, it has to be in 2 positions. Please, this is important message to be delayed unless Dr. Ayman عايز يضيف حاجة تانية.
Or dedicated venous duplex study, including the abdomen and pelvis, even trans-abdominal or trans-vaginal, with dedicated also lower limb, because the lower limb venous duplex, because this identify actually the significant leaking point in lateral or extra-axial varicose veins, which have to be managed with the initial intervention. Usually it is injection, يعني whether glue or foam, but it have to be managed with the initial intervention for pelvic venous disorders.
قويه جدا مع احد زملائكم في القسم الراديولوجي، بتقولوا احنا بندور على كذا ساعتها، وبليز ميك شور ان هو قدامك be it a duplex or a CT venogram in the supine and then in the standing position, because sometimes the artifacts are there give you a false positive result, especially at the iliac vein axis. وشكرا جزيلا. دكتور ايمن انا احب
For this topic also الحقيقه ان احنا كان لينا توكس مع مؤتمر الاوبيجاين بتاع عين شمس، كان مؤتمر قوي جدا، كان في نفس القاعات دي، والحقيقه عملت برزنتيشن انا والدكتور حجاج على غطينا كل البلفيك فينس ديس اوردرز والفاريكوز فينز اسوشيتد مع الجاينيكولوجيكال ديزيز اللي موجوده، والحقيقه كانت وبريزنت اور سيلف ان احنا كان مانج سبيشال السورس بتوع البيشنت دول مين اللي بيبقى جاي من الاوبيجاين كلينيك. اوكي، فالحقيقه كانت عملت ريبيتيشن كويس جدا يعني، وده برضو اللي بطلب الشباب يبريزنت اور ورك للكوليجز بتاعتكم في الاسم ده، لان ده السورس بتاعنا الاساسي. اوكي، شكرا جزيلا، و this is the end of the session. اوكي، شكرا.